Hello, and as you've just heard, my name is Carina Venter. I'm an allergy specialist dietitian, and I'm very pleased to be here today to discuss the role of diet indices, diet diversity, and general nutrition in allergy prevention. The objectives of my talk today in brief is allergy prevention and diet diversity, and also what does diet diversity mean? Allergy prevention and diet indices, and again clarification on what diet indices refer to, and then the role of nutrition in allergy prevention, and we will do a brief discussion of important nutrients, or the nutrients at least that we think that's important in allergy prevention. And so the definitions: diet diversity. Diet diversity in simple terms can be defined as the number of different foods or food groups consumed over a given reference period. So this may be the number of fruit and vegetables consumed over the last 3 months. It could be the number of allergens consumed over the first year of life, or it can just be the total number of different foods consumed over the last week. Diet quality has no official definition in the literature. The definitions vary widely, and many different measurement tools are used, and I will take you through a few, such as the Mediterranean Diet Score, the Healthy Eating Index, and the Diet Inflammatory Score. But diet quality in its essence reflects nutrient adequacy, although it is not always the case. And the use of a diet index, like I said, I'll take you through a number of examples, but the most classic one is the Mediterranean Diet Score. So what does diet diversity mean, and particularly in relation to allergy outcomes? And you know, normally when I have a question in my mind and nobody seems to be able to answer it, I get a group of experts together and I write a paper. And so I got a group of about 30 experts across the world together. They are experts in allergy, immunology, the microbiome, nutrition, and the project was also led alongside Dr. Liam O'Mahony from Ireland. And we wrote a paper, the APAAACI position paper on diet diversity in pregnancy, infancy, and childhood. And many of the slides that I will share with you today is actually data derived from this paper if you wanted to look it up. So as we were writing the paper, at the time there was only one study published looking at diet diversity and food allergy as an outcome. I will briefly refer to other allergic outcomes today, but the emphasis of my talk will be on diet or nutrient intake versus allergy outcomes. And so at the time, when we published this paper, like I said, we had the one paper from Caroline Ruday showing that increased diet diversity over the first year of life was significantly associated with less food allergy by 6 years of age. And I will get back to Caroline's beautiful data towards the end of my talk. But then since the publication of the diet diversity paper, I published my own data from the Isle of Wight, where we used different measures to define diet diversity. We looked at the WHO definition of minimum diet diversity as 6 months, the number of foods introduced by 6 and 9 months and also 3 months of age, the number of food allergens introduced over the first year of life, and then the number of fruit and vegetables introduced up to 9 months of age. And strikingly, we saw that as the number of foods increased by 6 months of age, so these babies were weaned very early, for each additional food given by 6 months of age, we saw an 11% reduction in food allergy by 10 years of age. And as the number of allergenic foods introduced by 12 months of age increased, so did we see a reduction in food allergy outcomes by 10 years of age. In fact, with every additional food allergen given to these infants by 1 year of age, we saw a 33% reduction in the odds of food allergy by 10 years of age. So, you know, the message from this study was clear, you know, let the babies eat. If they're ready to eat before 6 months, they can start introducing foods, hopefully a variety of foods alongside breastfeeding. And we shouldn't be scared to feed them the food allergens, and each additional food allergen increased or reduced the risk of developing food allergy by 10 years of age. And I'm not giving a talk on the microbiome today, but it's always interesting to look at the possible mechanisms behind it. And here we can clearly see, when we look at the data from Lawson et al., as the number of family foods increased over the first year of life, so does the microbial diversity measured by the Shannon index increase as well. And I will show you later, or briefly mention data indicating that increased microbial diversity is associated with reduced food allergy outcomes. Very interestingly as well is when we look at increasing fiber intake in the first year of life, we also see increased microbial diversity, which could possibly be associated with reduced food allergy outcomes. But we see an opposite effect when we look at a fat intake. So perhaps we don't want to give babies too much fat in the first year of life. And I'm not talking too much about early introduction of allergens other than these few slides, but that perhaps is something that we need to take into account when we introduce multiple nuts into an infant's diet in the first year of life, as these foods are very high in fat. Getting back to Caroline Reday's work, she also clearly showed that in these babies with the increased diet diversity and less food allergy outcomes, when we focused at particular diet patterns, so diet quality, the infants who ate more yogurt, fatty fish, and fruit and vegetables had an increased microbial diversity characterized by increased butyrate production. They found increased expression of T regulatory cells with its cytokines IL-10 and TGF-beta in the infant's gut microbiome, and they also saw reduced atopic sensitization, asthma, and food allergy up to 6 years of age. So really nice data demonstrating diet diversity. The foods we eat within the diet diversity has got a mechanistic effect on microbial diversity, the metabolites found in the microbiome, the immune system, and then finally reduce clinical outcomes, which is really what matters at the end of the day. So that's sort of like what we know about diet diversity. There's no data on diet diversity in pregnancy and lactation. So if we then move on to diet indices, here we found no data on the lactating woman's diet and infancy, but we have some data on the maternal diet in pregnancy. And so the first set of data, I'll show you studies where they looked at Mediterranean diet intake in pregnancy and allergy outcomes in the infant. And as you all may know, the Mediterranean diet is characterized by intake of potato, white meat, some red meat, but not a lot of processed meat, some eggs and some legumes. It also contains olives. It's very interesting. There's a huge debate on whether dairy really classically belongs within the Mediterranean diet. But according to the score, there is a positive point given towards dairy food intake. Fruit and vegetables are also an important part of the Mediterranean diet, some herbs and spices, and then also other grains such as bread, pasta, rice, and couscous. So using this score to characterize the maternal diet in pregnancy, a number of studies looked at allergy outcomes, and very disappointingly, out of the 6 studies we have, only 1 study found any significant association between maternal diet intake and infant allergy outcomes, and they found reduced prevalence of persistent wheeze, atopic wheeze, and atopy in the infants. But the other studies found no association, despite the fact that they looked at many different allergy outcomes, although none of these studies actually looked at food allergy as an outcome. If we then look at healthy eating index, the healthy eating index is the American way of characterizing the maternal diet. And particularly the maternal diet in pregnancy is characterized by the alternative healthy index for pregnancy. And if we just focus on the maternal diet for pregnancy, you can see that there's a positive score given to calcium intake, a positive score given to iron intake. None of these 2 nutrients have really ever been shown to have a clear effect on allergy outcomes. And then a positive score towards folate acid. And as we all may know that, folic acid or folate has its own very sad story when it comes to food allergy outcomes, where we've seen from observational studies that prolonged high-dose folate intake is associated with food allergy outcomes, but clearly nobody's ever going to do that RCT because we don't want to increase the prevalence of neural tube defects. But nevertheless, using this score compared to allergy outcomes, it was no surprise when the outcomes was disappointing. And so 2 studies reported on healthy eating in pregnancy and offspring allergy outcomes. The one is the data from the Boston group by Lange et al. And they showed no association between healthy eating index in pregnancy, recurrent wheeze, doctor's diagnosis of asthma, eczema, lower respiratory tract infection, or atopy at any time. And they followed the infants up to 3 years of age. When we look at my data from the United Kingdom with Harriet Moonseng as the first author, we found no association between the alternative healthy eating index in pregnancy and any of the allergic outcomes we studied, such as sensitization to food, aeroallergens, any allergen and allergic disease, any reported allergic disease over the first 10 years of life. So then moving on from the Mediterranean diet and the healthy eating index in pregnancy, we thought, well, perhaps the answer lies in the inflammatory index of the diet, particularly in relation to wheeze or asthma outcomes. Because again, as we all know, that even though there is an allergic component in some forms of asthma, most forms of asthma has got a big pro-inflammatory component involved in symptoms and the progression of asthma. And this inflammatory diet index is slightly alternative in the fact that, you know, we take things such as turmeric and ginger into account, which is not normally food or food components that we would take into account in just normal standard healthy eating. And then when we look at the diet inflammatory index in pregnancy versus allergy outcomes in the infant, we have 2 studies that we can quote at this point in time. And the study from Ireland actually showed that there was some association between the pro-inflammatory diet. So the women who had a less inflammatory diet, children had less asthma by 10 years of age, and the women that had a more pro-inflammatory diet had their children had the higher risk of developing asthma. But that wasn't the end of the story, because again, the group from Boston then presented data where they showed that higher DII scores, so a higher inflammatory diet, was associated with wheeze trajectories, but not with asthma. And so we have 2 studies with slightly different outcomes, and we're really not clear whether a pro-inflammatory diet in terms of asthma or wheeze outcome in the infant is the answer. I have currently a paper under review where we looked at wheeze and asthma in children up to the age of 4 versus the maternal pro-inflammatory diet index, and we also found no association. So in terms of diet in pregnancy and allergy outcomes in the infant, we haven't really got an answer. I did wanted to just at least show you the paper by Dr. Miyake, where they looked at different diet patterns in pregnancy versus allergy outcomes in the child, and they found no association between healthy eating, the Western diet, and also a Japanese diet pattern and allergy outcomes in the infant. And the Japanese pattern was defined as high consumption of rice, miso soup, sea products, and fish, and low intake of bread, confectionery, and dairy products. In the unadjusted model, they did so very bizarrely, and protective effect of eating according to the Western diet, which is, you know, characterized by high levels of fat and trans fat intake and wheeze outcome in the infant. But after they corrected for all the different covariates, they lost that significance. So really, you know, in terms of data from Japan, we're also not any clearer. Although I was secretly hoping that the Japanese diet pattern is going to give us the answer about allergy prevention, because it does reflect a very healthy intake of food. I then, you know, moving away from diet patterns and diet diversity, I did a paper with scientists from Germany, one of our fellows in Colorado, and a fellow dietitian in America, and we looked at nutrition and allergy or immune system outcomes, and we called our paper Nutrition and the Immune System, a Complicated Tango, which it truly is, and there you've got the full reference of the paper. I'm not going to go into the nitty-gritty of the tables in the paper because it is the next 4 slides are pretty busy slides. But I think the overall picture I want to show you is that when we look at nutrition either as patterns, as food, the way that food was cooked or produced, or the actual nutrients in the food, it may have different effects on different aspects of the immune system, such as the gut barrier function, inflammation, and then very importantly, the microbiome. And so we can see that overall diet can affect the microbiome. The Western diet, especially a high-fat diet, has got a negative effect on the gut microbiome, particularly gut microbiome diversity, and that a higher diet diversity, a diet higher in diversity is also associated with increased diversity in the gut microbiome. I've showed you the data already for infants, but it's also true for adults, and this particular study I'm referencing here was conducted in the elderly. The Western diet may have a negative effect on the gut barrier function. Then if we look at nutrients and how it affects the immune system, you can see that omega-6 fatty acids surprisingly enhance the tight junctions. We normally speak very negatively of omega-3 fatty acids because they're omega-6 fatty acids because they're considered to be pro-inflammatory, but they also have their good place. So, you know, here you can see that the omega-6s actually enhance the tight junctions. There's a long list of vitamins and amino acids and how that may either increase or reduce inflammation. And then again, amino acids per se can affect the gut microbiome as well, and the bacterial products produced by the gut microbiome. Other nutritional factors and the immune system, I don't want to go through all of them, but I do want to highlight just 2. This is just data from murine models. We don't have any human data to prove the point, but the way that we cook food, so any dry heating, so like when we make burgers or when we make toasted sandwiches, we produce advanced glycosylated end products, which is a combination of heating carbohydrates, protein, and fat in some cases. And these products have a very negative effect on the gut microbiome, and they also affect IL-33 and TSLP. So what I'm trying to say with this information is that perhaps it's not just the food we eat or the nutrients they have, but it also the way that they cooked or heated may also affect allergy or immune system outcomes. And then, of course, never forget processing, because we can see that emulsifiers, particularly the polysorbate 80, in America, that is present in a mayonnaise called Miracle Whip. And these emulsifiers have a negative effect on gut barrier function. It may promote inflammation, and it also has a very negative effect on microbial diversity. So again, not only do we need to focus on the patterns of food, the actual food we eat, the nutrients in the food, the way we cook them, but we also need to think about food processing and what we add to food during this processing period when we want to study allergy outcomes. And then finally, the food preparation has got another angle to it, where we know from studies that if you eat food fresh or raw, it has its own natural microbial load, which can affect the gut microbiome load. But if we have processed foods like baby food, for example, by definition, they have to be sterile, so they have no natural microbial load. And so perhaps having more uncooked food and raw food opposed to processed food or, you know, canned food, we may also have a diet that's more beneficial for gut microbiome diversity. So we need to think about many factors when we study diet, nutrition, and allergy or immune system outcomes. Then I wanted to just focus on 2 nutrients, just because the data is so different than what is normally preached. Yes, of course, vitamin D is an important nutrient, and of course, vitamin D directly affects the immune system. But in the next few slides, I'm going to show you that too much of a good thing is never a good thing. And so when we look at RCTs, I'm just showing you data from RCTs over the next few slides. And we just focus on vitamin D supplementation versus food allergy as an outcome. So I'm not looking here at the other allergic diseases. You can see that high dose vitamin D supplementation in pregnancy is associated with an increased risk of food allergy in the infant. When we look at high dose vitamin D supplementation in lactation, we also see an increased risk of food allergy in the infant. And the same is pretty much true when we look at high dose supplementation in infancy. And I want to make a point here to say that the comparison group, so the control group, had the 10 microgram or 400 international units as recommended by the Institute of Medicine, but the group that had 3 times that amount, so 30 microgram, they had the increased risk. So please, do supplement according to your national guidance. Do focus on the importance of vitamin D intake through pregnancy, lactation, and infancy, but don't over-supplement. And then we see similar pattern for fish oil supplementation. In pregnancy and breastfeeding, we see in one study a reduced risk, but 2 studies an increased risk. And then when we look at fish oil supplementation in infants, again, we see this should have been in red. I do apologize. Oh, no, it is in green, a slightly decreased risk. But definitely the omega-3 supplementation trials in pregnancy and lactation give us a bit of a muddled picture. And the ones in pregnancy only showed an increased risk. So perhaps what is good in pregnancy or not good in pregnancy may not always reflect what's good in lactation and what's good in infancy. And so we really need to look at different dosages and different time points of supplementation before we can give any clear guidance on how much to supplement with and who should be supplemented. When we look at fish oil supplementation in women that was breastfeeding and then the supplementation was continued in infancy, again, we see an increased risk. So perhaps prolonged supplementation or the duration of supplementation alongside the dose of supplementation and who should be supplemented should really be studied a bit more as well. So really, I've taken you now through a number of concepts about nutrition and allergy prevention. I think there's a lot of work to do. I think, I hope I've showed you clearly that everything in food allergy prevention is not just about the mighty peanut. We need to think about overall nutritional intake in terms of diet diversity in infancy and allergy outcomes. For the other allergy outcomes, things may be a little bit unclear, but I think the data about diet diversity in infancy and food allergy outcomes clearly indicate that it may have a protective effect. In terms of diet indices in pregnancy and allergy outcomes, we definitely need to study more populations. We need to define pregnancy intake much better. Nutrients, food, cooking, and processing can all potentially affect the gut microbiome, gut barrier function, immune system, and subsequent allergy outcomes. The most studied nutrients are omega-3 fatty acids during pregnancy, lactation, infancy, and then some studies started in pregnancy and lactation and then continue during infancy. But I think the safe guidance at this moment is to stick to the recommended intake, but don't over supplement, because really too much of a good thing, as we all know, is never a good thing. So with this, I'd really like to thank Dr. Ruby Pavankar for the invitation to present here today, and then my many different collaborators across the world, in particular my APAAACI collaborators, the people from the Isle of Wight that didn't kick me out when I decided to move to America. I still work closely with them really on a daily basis, and then the wonderful team in Colorado that's very supportive both clinically and with my research endeavors. Thank you very much, and I now look forward to the discussions during the question and answer session.
Thank you, Professor Venter. It was excellent and really enjoyed your talk. It is so informative, and I believe it's going to be so useful for our membership and our community of the Asia Pacific region and of APAAACI. So we deeply appreciate your efforts in preparing the content and in delivering such an excellent talk.
Thank you.
at this time of the night where you are. So deeply appreciate that even more.
Thank you.
So I have some questions that I'd like to go across with you, and
Yeah.
we're grateful for the answers. In your talk, you talked about diet diversity, and this is a very, very important area, I think, especially in infants and in children, and perhaps also from a maternal point of view. So I'd like to ask you that is the diversity of children who have food allergies impaired?
You know, we don't have any published data on that other than my own data from the Isle of Wight, where we showed that in children with cow's milk allergy, their diet diversity is impaired. And beyond the fact that they were avoiding foods with cow's milk, you know, so things like butter and ice cream um, and milk itself, the diet diversity in terms of other food groups was also impaired. And we think it is because of the feeding dysfunction or the food aversion that often coexist with food allergy. But there's definitely something that we need to study. I mean, in effect, by telling somebody that they have a food allergy, particularly if you advise them that they have multiple food allergies, you are taking lots of different foods and food groups out of their diet. And so my guess would be that if we look outside of cow's milk allergy, we would see even more of an effect on the reduced diet diversity in children with food allergy. The question I also have is whether that may affect their microbiome and may reduce their chances at becoming tolerant of the food or the foods that they are allergic to. So very good question, but we don't have clear answers, and a lot of work needs to be done in that area of food allergy as well.
Thank you very much. Actually, I was just about to ask that question, when you touched upon the microbiome. Um, I was just wondering that if there is enough data to show that having a greater diversity of the food in early life would help in actually having a more stronger immune system and a better microbiome profile.
You know, this is again, you know, something that if you just listen to presentations at conferences, you think like there's must be hundreds of papers and studies addressing that. But they literally, the two studies that I'm aware of looking at diet diversity and microbial diversity is, like I showed, the data from Lawson et al. And then the data from Caroline Reday's group. And so we definitely need more studies that's looking at the whole picture of diet diversity, microbial diversity, and then infant food allergy outcomes as well as other allergy outcomes. So hopeful data at this point in time, but we really need more data to confirm what we think we know.
Yeah, thank you so much for this very important aspect. And I would actually even go beyond allergies, because I would just presume that having a better diversity of the food in early life could help the immune system and also help in other non-communicable diseases like obesity, or programming for other diseases for the future. So do you have even, if there's not enough data, but if you have an opinion that how a better diet diversity may impact obesity and other diseases?
That's actually a good question and something I'm looking at. I'm really interested to look at my data, to look at children with better diet diversity and viral infections in later childhood. And, you know, on the Isle of Wight, we have 3 cohorts where we have diet diversity data in early life, and now we have viral disease outcomes up to 10, up to 18, and up to 32 in one of the cohorts. So we will look at that. I have looked at diet diversity in obesity in 2 of my cohorts. Disappointingly, I didn't find what I was hoping to see. It had no effect. But once again, I think, you know, power was an issue because we didn't have height and weight on many of the kids, so I couldn't actually do Z-scores in all of them. Really good question. I would hope to think that increased diet diversity in early life would be associated with reduced obesity and reduced viral infections. But I'm not aware of any papers. I search and I read and I look all the time. I might have missed something, but I think now with this whole emphasis on COVID-19 and the devastation we've seen around it, that there would be many studies now focusing on these aspects.
Very much. My other question is that should we wait 2 to 3 days between introducing each new food when we introduce new foods, just to make sure that the children are not allergic to the newly introduced food?
Yeah, you know, Ruchi Gupta published a paper last week about that, where she showed that pediatricians in the United States are very confused about this issue, because the AAP guidance still at this point say, or the American Academy of Pediatric guidance, to wait 2 to 3 days in between food. But the paper was really asking that this should be reviewed, as we know now that increased biodiversity, particularly in relation to food allergy, may have a protective effect, and nothing delays increased biodiversity more than waiting 2 to 3 days between food. So currently that's what the guidance is saying. I'd be hoping it would be changed soon. In my own clinical practice, I say to the parents, if it's one of the non-allergenic foods, just get one new food in every day. It makes sense to wait 2 days after introducing peanuts or after introducing egg, but there's really no good reason to wait 2 or 3 days after introducing apple before you're going to try a peach. But hopefully we'll see this change in guidelines pretty soon.
When you talked about apple, I just want to take the discussion a little different. Of course, I mean, we don't find allergic rhinitis or pollen, pollinosis in infants. Yeah. But of course, the onset of pollinosis and allergic rhinitis has actually, now seen in much younger children than earlier on, even at the age of 1 year and 2 years. You can find they're sensitized to it and they probably have symptoms, but we really can't differentiate it. So, and it's not so common to have the pollen food allergy syndrome in that age group. So I wouldn't expect that, as you rightly said, that we need to worry about apple and such kind of foods that may be affected by seasonal rhinitis. Am I correct?
No, and you make a good point. I mean, I know particularly the team from London published data showing that there are younger kids with pollen food syndrome than we used to think. You're speaking to the converted here, because I have very severe pollen food syndrome, particularly now living in Denver. So I feel I live with it, and I understand the academic bit behind it. But as far as I'm aware, we're beginning to see more aeroallergen sensitization in infants 2+. I hear what you say about 1+, but I think particularly when you look at cohort studies, become an issue 2+. And so I'd be surprised to see pollen food syndrome in a 6 or a 4-month-old infant. Having said that, the world of allergy keeps changing all the time. And I wouldn't be surprised if I say something completely different 10 years from now. The other concern, of course, about saying that the non-allergenic foods could be introduced every other day is when we do rice introduction or pea introduction, which is technically a low allergenic food, but we know it's 2 of the main triggers of APAAACI, where we may run into trouble. But I think as the prevalence of APAAACI is that low, I don't think it's a good enough reason to expose the whole of the population of infants to a very low diverse diet.
Thank you very much. My other question is, can we just eat to take butyrate supplements?
So this is, I have a very practical, simple brain within this very complex area I work in. And so when I started to look at all the butyrate data, I thought to myself, clearly there's got to be some food with butyrate in it. Can't we just eat butyrate? Then we don't have to worry about diet diversity or the microbiome diversity, because we put butyrate directly in the gut and we're going to have a lot of T regulatory cells and everybody's going to be happy. But interestingly, almost the only 2 foods high in butyrate is butter and ghee. And we have no data to show what happens to the butyrate in the food by the time it gets to the colon. So it's something I am highly interested in, and I'd love to study, because if the answer could be as simple as feeding the babies a bit more ghee, you know, it would just make everything we do so much simpler. But at this point in time, we just don't know. And you know, the other problem with ghee and butter is it's high fat foods, and I showed the data that a high fat diet negatively affect gut microbiome diversity. So we will have to be very confident that the ghee gets to the colon and it's doing its job there before we can start advising these high fat diets at mass.
Thank you very much. The other issue is that we come across this all the time, especially with the types of foods that we get, with the busy lifestyles that we lead, that people tend to have, you know, more than freshly cooked foods. I mean, we resort to having processed foods, and we actually give those processed foods to our children, and kids love to have, because there's so many fast foods and stuff like that, in addition to the, you know, the packed processed foods. So does processing of foods affect allergy outcomes?
So again, you know, I wish I could cite a study where they just looked at simple processed food in a high processed food diet in infancy versus allergy or food allergy outcome in the infant, but we just don't have the data. And so the best data we have is to say that a high processed food diet is normally high in trans fatty acids, high in fat. It's very low in natural microbial load. We therefore think it's going to have a negative effect on the gut microbiome and may affect allergy outcomes. I think something that I would love to see is some sort of cutoff. So I'm just going to take a step away from that. The American Gut Project showed that if you eat 30 different plant-based food a week, then that's your best chance of having a diverse gut microbiome. So from that, I'd love to see a study where we perhaps say that if you feed your infant so many pouches of baby food or so many jars of baby food, or if your child eats so many burgers a month, it's still okay, and it doesn't negatively affect the gut microbiome or allergy outcomes, because like you say, we all work all hours of the day and night. We're busy parents, we cook when we can, we feed our kids fresh food when we can, but there are odd occasions when you think tonight is the night where we're just going to eat something out of a box or a jar. And it would be nice to know that, you know, once or twice a week, once a month, 3 times a month is perfectly okay. But again, that's data that I would love to see published, studies I'd love to see done, because I don't think a black and white approach in the nutrition world really work in terms of you can do that and you can't do that. I think there's always a midway, but we need to know what the you know, what the cutoff points are for those midways.
Thank you very much. Excellent. My next question is regarding pregnant mothers, you know. So, you know, because we know that probably, you know, diet in pregnancy is very important. And, you know, it's interesting to know how that diet in pregnant women can actually influence the food allergy development in children, you know. So should pregnant women avoid allergenic foods during pregnancy, even if they are not allergic to it?
So the guidance at the moment say there's no need to avoid food allergens during pregnancy or lactation. It does not go as far as to say, but you must eat it. So I normally say to the mothers, do what you do. If you eat these allergens, continue to do so. And if you hate peanut, then there's just not good enough evidence to say that you now have to start eating peanuts. Probably because of the area of my interest, I almost weekly get asked to review a paper on maternal diet intake in terms of some or other allergen and allergy outcomes in the infant. And I can almost flick a coin whether the paper is going to say eating allergens is protective or avoiding allergens is protective. So I just think, once again, I'm sorry I keep saying this, I don't think the evidence is out yet to categorically say you must eat the allergens, but I think we're confident enough to say there's no need to put yourself on an impossible avoidance diet during pregnancy to try and prevent allergies, and food allergies in particular, in your infant. So just enjoy food and continue to eat the way that you normally eat, I think is the positive message that we can give to pregnant women at this point in time.
Thank you very much. That's an important and a crucial point, because I think many mothers actually, they come up with these questions in the clinic and they're actually confused, and there's so much information out there in the internet space that people are very confused.
And also, you know, the maternal guilt, you know, the amount of times I've had mothers sobbing in my clinic because the child's got a peanut allergy, and it's because they had the peanut when they were pregnant, or the child has a cashew nut allergy and it's because they had that one bar of cashew nut during pregnancy, and they beat themselves up and they feel so guilty, when actually, you know, there's no evidence to suggest they've done something wrong, and in fact the guidelines say no need to avoid them. So it's a lovely reassuring message to give mothers and at least reduce some of the guilt they may have.
Thank you very much. My next question to you is, what other factors can affect allergy outcome other than the food intake?
So, you know, it's interesting because the factors that can affect allergy outcomes are mostly also the factors that can affect the microbiome. But first and foremost, it would be the familial history of allergy. And so many studies have looked at both parents having an allergy. Some looked at maternal history, some looked at paternal history, some looked at a sibling with allergy. And it doesn't matter how you slice the data and which person you looked at. I think, you know, it's clear that a family history of allergy increases your chance or your risk of developing allergy. It's not necessarily always the same allergy that's passed on. So a mother with asthma may have a child with eczema. So I think that's one thing to be clear. And then, of course, other factors is method of delivery, breastfeeding duration, medication use during pregnancy, environmental exposures to pets in the house, for example, cooking methods that you use, whether you use gas cooking, use of central heating, air conditioning. So many different factors, you know, can affect allergy outcomes that I always like to have that list in my clinic, because of course mothers expect to come and see me and think I'm going to point my finger and say, you should never have eaten this, or you should have eaten more of that. And so I always say to them, of course diet is important, and we will go through all the points I've just discussed in my talk. But remember, there's a much bigger picture, and it's not just diet. There's many other factors that could have contributed to your child having an allergy.
Thank you very much, and I deeply appreciate the excellent talk and the question and answers and the good discussion. As I have said earlier, this is really very informative and useful for us. And I would also like to have something that would focus on patients, you know, how we can, you know, communicate better to the patients in a very scientific but also easy to understand way. So
yes, definitely. You know, I was involved in a session yesterday in Ireland with Audrey Gunville, and one of the things that came out is that when a child has a really large skin prick test, which we all know does not relate to severity of reactions, but that the mothers get so anxious when they see that big skin prick test that the whole consultation is almost lost on them, you know, because they're so nervous. And so I definitely think, like you've just said, you know, talking to the family and how the conversation go and how we explain things to them is hugely important.
I fully agree. Thank you very much. And we also look forward to having more insight from you on how we can actually involve the patient population in our region and get feedback from them through a survey or through different communication. So looking forward to such collaborations between you, your organization, and APAAACI too. So
Thank you. I would love to.
thank you very much.
Thank you. Have a good day.